This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code My DPC Story. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, patients pay their doctor a low monthly membership and, in return, build a lasting relationship with their doctor and have their doctor available at their fingertips.
It's the means of bringing back the focus on patient-centered care and wellness. This is Dr. Bhavana Rao.
I'm Sunil Vasisht.
And this is our DPC story.
Dr. Bhavana Rao went to medical school in India and then completed her residency at the Conroe Family Medicine Residency Program in Conroe, Texas. Prior to opening up her DPC, she worked at the Methodist Willowbrook Hospital as a hospitalist in Houston, Texas. Sunil Vasisht is Dr. Rao's husband and business partner. He holds a master's in electrical engineering as well as an MBA. He worked at Hewlett-Packard Enterprises for more than 18 years, where he led the global Internet of Things research and development team. Together, they opened Meridian Springs Primary Care May 1st of 2017. Welcome to the podcast, Dr. Rao and Sunil.
Thank you. Great.
Thanks, Marielle.
Yeah, great to be here.
It's definitely my pleasure. Because you guys are a team working together, what were the driving forces and circumstances under which you both decided to combine forces and start Meridian Springs Primary Care?
Well, when we started Meridian Springs Primary Care, we were both working in separate full-time jobs, and we grew the practice. We started from 0 patients, but we reached a point where we knew that it needed our undivided attention. And that's when my previous job ended. I came to the clinic full time. And shortly thereafter, in fact, it was January of 2019 when my husband, Sunil, joined me as well. And that was, I think, a turning point in the clinic's history.
What I jokingly tell people is the clinic story. If Bhavana is talking about that, she talks from the medical perspective. I'm the non-medical guy. I'm the technology guy. So she starts the story with her burnout and all of those things. But when I start with, hey, this was my MBA capstone project. So we have different stories, but it all comes together in the clinic. And it was my project. I used to work for Hewlett-Packard Enterprise for 18 years almost, and I resigned in 2019 to focus full-time to grow the clinic. But when I was doing my MBA, I was looking for a capstone project that was not related to technology. And at the time, she was reading, in journals about this membership-based clinic primary care, the DPC that, I think at that time, probably less than 150, 200 people doctors had started around the country. And out of curiosity, she was like, "Do you want do a feasibility study of that?" And it was a good thing. And I did some research on some practices that were started at that time. For me, at that time, it was, is this material worth 1 year of work? Because that's what I wanted to fill 1 year of work, and it looked like there was a lot of things to be done that would fill that. So I agreed, and once I started it, it was an eye-opening experience, at least as a non-medical guy, what was going on and how radical this was. And so that's how it interested me. So that's a non-medical perspective of the Meridian Springs story.
When you guys were making that transition and you were working on this as your capstone project, Sunil, the DPC movement, like you explained, was not that big. And so what were some of the pieces of information that you were working off of, or the assumptions that you were making that might have changed during your process to create Meridian Springs?
When I was looking at, at that time, there were two practices in Houston. Milepost was one of them. And what was the other one? It's Our Way, and it's now changed to First Primary. But they were the only two that was there, and we met them. They were very helpful and forthcoming with all the information. I had a whole huge questionnaire that I was asking questions, not just on medical side, but also financial, the revenues modeling and all of those, and cost structure and all that. And until then, I had never, ever given a thought on health insurance because it was coming through HP. And so every year it was the same thing. But then that was the first time I actually crunched the numbers to see what we were paying and what kind of benefit was available. So it was eye-opening. And so in terms of, at that time, it was a very common thing to compare it to a car insurance. And this is used by all DPC practices to highlight how DPC works, compared to others. So those kinds of assumptions, it was very helpful for me to understand from, I would call this the Stockholm syndrome, because people are used to one kind of way of doing the healthcare. And, even though it's dysfunctional, they still continue to do that and never ever think of other better alternatives. But then when forced to think, it was an eye-opening experience for me. The numbers were too big, and I was so surprised that I'd never ever given attention to that.
And Bhavana, what were your assumptions having been a hospitalist transitioning to a direct primary outpatient clinic?
Well, of course, it was an exciting moment or not exactly a moment, but the whole process was exciting for transition, but also nerve-wracking because I had never worked in a clinic, let alone establish a clinic. It seems, I think the system is very focused on employing doctors, and the knowledge is taken away or not shared with us on the administration side of things. And a lot of things is like in the current work environments is like, you just see patients, we'll take care of the rest of the things. And now I had to educate myself on the rest of the things. So that was exciting as well as nerve-wracking. I learned that I really enjoyed that part of it, because we all know to see patients. We have been trained to diagnose, we have been trained to treat, but we don't know anything else. We don't know lab draws. We don't know how to talk to labs to establish accounts in different, and even medical supplies. So all of these were, small things, but building blocks of establishing a clinic. And there were so many things at that point. And, and that's the part that was super exciting for me. Plus, it was going away from a work model that I was getting exhausted with, which I couldn't see myself getting ahead in any way.
Can you give us a little bit more detail as to what was your work week like typically before you started making your transition?
Well, as a hospitalist, you have some flexibility with the hours, and initially it was a little bit different. It was a lighter workload when we started off, but as the group grew and the patient loads grew, but again we had shortcomings with calls. We had a 11-day or a 12 or a 13-day block work schedule, and of course that means every fourth day call. And of course, if you're on a weekend, then there's a weekend call, and uh, extra patient load on the weekends, because two of us would share the load of rounding on weekends. And we all know that there are summers are lighter in the hospital, and then winters are worse. And I remember rounding on about 45 to 45 patients one day, and I could see no betterment in the situation because of the way the system is, because of the insurance system, the billing system, and the hospital system, of how they wanted the coverage and what things they wanted done. So these I couldn't, and then I felt like I was just giving orders. I was not doing anything else. I had it. It made me wonder that, is this why I got into medicine? And when I thought of that, I just thought like how excited I was getting into medical school and becoming a doctor. And I felt very sad that I had just lost that excitement. And I just wondered that, where did it all go? Is this it? Is this my life? So that was the point where I was looking at other ways of practice. Like, what am I going to do in the next 5 years was my question in 2016. So that's when I was reading about DPC in a lot of medical journals and magazines. And then I saw Dr. Stringfellow's clinic, Milepost, open. And I was so excited to see her do that. And DPC became a reality to me because, I knew a doctor doing it in this area, starting her practice about DPC in this area. So that was that brought this DPC concept from just medical journals and articles to real life. And that was the moment where I felt like, yes, this is the way to go, where you're not controlled by insurance. And that was in 2016, a lot of the private practices were being bought up by hospitals. People could not maintain their own practices. It became, we saw this change take over. And there was no way I could open a private practice with insurance and think that I'm going to be successful financially. But DPC brought a way that, a physician could be independent again, could have his or her own practice without the burden or the threat of somebody overtaking it.
Just hearing your story, I can't imagine 45 patients on your rounding list. I mean, I remember in residency, 16 was a really bad day. And although, yes, I was a resident and not an attending at the time, 45, it's just how can you take good care of people, And I am glad that you had in your community someone that was showing you that this is a real thing. It's a tangible thing that you, as a doctor who had not gone to business school, could do. And that's absolutely wonderful that, Sunil, you were also able to, create this as your capstone project. But the idea that you guys were looking to the future, I think that is so important, because especially if you go from residency to an employed position, thinking about the future, it happens all the time when it comes to, your 401k or your children's future, but not necessarily what do I want in medicine. And I think that a lot of people can relate in that you felt that dissatisfaction with medicine to the point where you were questioning, why am I doing this? So, it's everybody has their breaking point. And I love that you guys strategized about it and had that business background, Sunil, that you brought to the picture.
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes.
Yes, it was. I still remember that afternoon. I just called him. I told him about this. And I said, I want to do this. That's all. It was like an emotional decision for me. But of course, Sunil being Sunil and doing his MBA and his experience in corporate business world, he said that, okay, hold on, don't just jump into it. Okay. And then I was like, and of course I was like, don't brush it off. And, I had a typical emotional response, but I think he then took the time and evaluated the whole model for his project. And that's the first time he got interested in medicine.
Yeah, exactly. Because until then, I had ignored healthcare. I did not want anything to do with it. And I did not want to know what she was doing. And I knew that she would come back home all exhausted and kind of burnt out. That's what I saw from my side. And yeah, when she called and told me about this, because my first proposal was shot down, I always wanted to do a capstone project on finance, and this was really not in my radar. And when she told me, I thought this was another shiny thing that she wanted to get on and then move on to another shiny thing. And that's why I said, hey, just hold on, don't jump onto this. We don't even know what this is. It might be a passing thing. Little did we know that we are going to start. Only about a year later, we would start our own clinic.
That's such an awesome story. You guys were, in fact, blossoming entrepreneurs. How fantastic.
We didn't realize at that point, but I think it just grew on us. And I think we were really excited with the whole venture. And even then, of course, Sunil had done the business plan, and he was in his mind more cautious. For me, I feel like as a physician, been through the system of hospitalists, couldn't see any other way of practicing in the future. It was my way out of being in an employed position and having something of my own for a change. And that's where we began the whole journey of, at that point, I didn't think that how I'm going to get patients. And I just started with zero. We built the practice, it was a really a day by day growth of the practice. But I think the first few months we didn't even know that we were not focusing that much on it. We didn't know. It was a growing process. And I feel like, I think everyone goes through that. But looking back, I think we were so excited to just start it.
That said, I want to talk about your community and your population of patients. Can you tell us a little bit about the Woodlands and what the environment is and what potential population you have for patients around you?
Woodlands is very well populated. I think it's a very good area, very residential area. We are in a location where there are a lot of schools and a lot of neighborhoods. But my clinic population, I think I would say they are all young families, young kids to teenagers, and adults, usually between, most of them younger than 50, I would say. For some reasons, my practice, we don't have a lot of Medicare-aged patients. So it just varies. We have a lot of small business owners as patients and, contractors or people who are self-employed. They form a majority of my patient population.
And Bhavana, over the years that you guys have been open, has your patient population changed much?
Not really. We've had, we've had this very common thread amongst all my patients is most of them are self-employed.
You guys have a brick and mortar clinic. Can you describe your space and how you found your space?
Sure. Our clinic is about 1,200 square feet, 1,400 square feet. We have about 4 rooms and a break area, a restroom, and a front sitting area. So I have set up one room as my office and one room as an examination room, which includes procedures. And then we are yet to furnish the other exam room. We have partially furnished. We basically are going to set it up as 2 exam rooms. And then my husband occupies one of the rooms. We looked for a realtor who could help us. We looked at different locations. I wanted the office to be very close to my house. So literally it is 2 miles from my house. And that was a key, that was a very important factor for me, that it would be very close and I'm not driving 30 minutes to get to my office.
And do you guys have employees in addition to you and Sunil?
We have one assistant.
And is that assistant a front office person or a medical assistant?
We don't have a front office as such because everything's online. Appointments are scheduled online. We have the medical assistant answering phone calls and assisting with patients also.
Have you guys stopped accepting patients?
We are close and, we are in the process of looking for another doctor to join us, to hire another doctor so that we can grow the numbers without compromising on the personalized attention we can give to patients.
And Bhavana, how did you decide that you wanted to bring on another doctor?
We want to maintain the DPC patients to doctors ratio, which is usually about, I guess, anywhere from 600 to 800 patients per doctor, depending on how sick the population is. Or I think some doctors describe it as younger, healthier versus older and more complicated patients. And given that range, that's what helped us decide on it's time to look for another doctor to hire. And I understand that, it's a long process. I don't think it's a quick one. So the whole idea of getting on another doctor to the doctor actually walking in the door might take about 6 months or 8 months. Not sure at this point. So I think it's a fair thing to say that we'll have enough patients for the doctor to start working with.
In terms of searching for an additional provider in your clinic, how have you gone about looking for someone who would be a good fit?
So basically, we are looking for a doctor who's entrepreneurial, passionate about DPC. And I have never hired a doctor before. So it's a new process for me. And I think I'm using the regular means of how DPC practices nowadays are looking for doctors. That's on Facebook DPC groups.
Especially with you looking for someone who is DPC centric and entrepreneurial, I think that's a great place to look.
Yeah, I think I would just start from there and then see if my friends or my contacts have anyone who's interested.
It's definitely something that DPC practices who are looking to grow, or DPC doctors who are, envisioning their retirement in the future, are being challenged with. I know that in different parts of the country, the demand for DPC docs joining practices is different, but at the same time, I think that it's something that as a movement we have to look to and network about, because this is how we keep the movement growing and how we get more patients to join direct primary care.
I think so. And I think, it'll get smoother and easier. I see that residents are starting DPC practices out of residency and planning their practices during residency. So that's a very positive change. I think that will encourage more people to think about joining practices and, growing them or joining growing practices.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
What about your previous hospitalist group or other associates that you had at your hospital? Are there any who, after you opened, started asking you about, hey, what is direct primary care?
Oh, definitely. Definitely, they were very interested. And, a couple of them are even planning to start, but COVID hit and then they had to put their plans on hold for various reasons. The year when I started DPC, I had a problem with labs and, to order labs. And of course, I wanted to draw my own labs. And I feel it's funny now, but back then, it was a very daunting task to draw labs, and I didn't know the different tubes used for different lab tests. I felt it was also alien to me. And look, now, of course, it's very funny. I still remember the first patient I drew labs on. I was so nervous. She's still my patient. But I was trying to draw labs on my patients in the hospital. So I was just asking the nurses I knew, and I would tell them that I would draw the labs, and I wanted them to show me how to do it. And how to position myself and how to basically do the whole process. So my friends saw this and they were kind of laughing that, what are you doing? They couldn't believe it that I was trying to draw labs on patients. But they were the same ones that came to my clinic a year later, and they wanted to know all about my practice because they were ready to leave the hospitalist job and start their own clinics. And it was funny. I made them give me my flu shot, and they were nervous as hell to give me the flu shot. And I think it was a very funny scenario. They told me that now they understand why I was answering my own phone calls. And, I was pretending to talk like a front desk person to my clinic phone while I was on the floor in the hospital. And one of my friends saw me do that. And it was very funny at that time. And they wouldn't understand what am I do? What are you doing? That's what, those are the looks I got. So it was all very funny. And when they came to my practice, they told me that they told that, yeah, we remember you doing all those. And we thought it was so hilarious at that point. But it's so good to see your clinic now, which is open. And yeah, so I felt very happy. I was very, very thrilled that they were encouraged and motivated to start their own practices.
The idea that you can open your own practice, especially from a hospitalist perspective, I mean, how often do you guys think about outpatient care? When we were on hospice rotations, it was very much, who is their outpatient doctor? Let's get them, their appointments set up for transfer of care. But that's where the thoughts stop. I can't imagine that thinking about transitioning to outpatient care is something that is readily thought about when you're, bombarded with 45 patients and 13 days of work in a row. But how exciting that you inspired other people. That's how you are getting the movement to move forward as well.
Yes, I think so. I think each of us has to help the other doctor come up. And that's when, I got help. The whole DPC community was open to help us with our questions and with my husband's research. And we are really grateful for that. And I think the same way, if anyone approaches me as to how to start a practice, and I've met several of the doctors in the last 2 years who wanted to talk to me regarding setting up a practice. And I felt very motivated to help them the same way, in the same spirit of how I received help from other doctors and how they opened their doors for me to understand how to set up a practice. And I think that is one factor that has really helped the whole DPC movement.
With you sharing that, I want to ask about your guys' involvement in the Mid-Texas DPC Alliance.
It's a
Greater Houston DPC Alliance. So it's anyone who's offering cash-based practice, from my understanding. So it has a group of specialists also, and a way for the people to connect. So we are a part of the group.
The reason I'm asking too is because like California, we have one and we do monthly Zoom meetings. Do you guys have any regularly scheduled times where you meet or do masterminds or anything like that to keep each other in the loop about Texas and DPC in Texas?
Yes, we have a monthly Zoom meeting.
But it's not Texas, it's Houston, Greater Houston. So
Okay.
if you're talking about that one, that's the one we are part of. I think it's called the Direct Care of Greater Houston, and I think that's the one. It's something where if somebody goes to that website, they can see the list of all the practices. It's kind of a resource and a way of keeping in touch with each other. At least at this point, it's a kind of one place where you can see what is available. And so we also joined that, and we are also listed on the website.
But I think the parent, the DPC Frontier, I think is the ultimate DPC with the DPC mapper, and it differentiates hybrid versus pure DPC practices. And I think all of us are on the DPC mapper and with the DPC Frontier website. So that would be, I guess, the ultimate reference.
And it's definitely a growing resource, but that's fantastic that you guys have a community that you've built within the DPC universe to help each other out in the greater Houston area.
Yes, because as we see, there are so many new people coming in to the picture, starting their own practices. So it's a huge movement. And I think it's a great place to keep track or even come to know of different practices coming on and different specialties coming on.
Do you guys have specialists that are direct care specialists around you? And how easy is it for your patients to access their care?
Yes, we are blessed with a group of direct care specialists who have great cash pricing for their visits and evaluations, especially dermatology, cardiology. I think most of the common specialties, we have GI, so we have cash-based direct care physicians doing that.
And in terms of your own clinic, what types of procedures do you offer to patients?
Well, I'm family medicine trained, so we do small office procedures like abscess drainages, toenail abscesses, anything with a local anesthesia and which can be easily managed in the clinic.
And are your procedures included as part of your membership or are they separate?
We charge a small fee for the materials we use for the procedure. Like say if there's a laceration, suture, or it's a very small cost.
In terms of bringing value to your practice as well, I wanted to touch on that on your website, you guys list that you guys will also provide service or care to international visitors. How did you guys develop this idea and what part of your practice is composed of international patients?
Yes, we do that. We see international visitors mainly because our parents are in India and they visit us. They come to the US for 3 to 6 months to stay with us periodically. And we live in a community where there are a lot of Indians, and the same thing. Everyone's parents come visit them. They live with them for 3 to 6 months and go back. So when they come here, they don't have access to primary care. They end up going to urgent care. It becomes very expensive. And many times the parents don't take care of their health issues because they don't want to burden their children with high costs. And we saw that with our parents. We saw that with our friends' parents. So when we started the clinic, we had an opportunity to offer a similar membership-based model, but for a shorter period. And they could join our practice for 3 to 6 months, get the same primary care. They would have access to medical records, and they would have access to discounted lab prices while they're here. And they could continue taking care of their problems. And then when they go back home and come back again, we would still be there. We could continue with whatever care their doctors back home had advised them to go on with. So these parents keep coming back year after year. They need a primary care here. They need a primary care back home. So we offer to do that for them. And I think it was very gratifying for us to be able to do such a plan for the visitors.
well, with you guys being in the greater Houston area, I mean, you guys are right next to an airport. You described your community as with a heavy Indian population, and the idea that you guys are continually taking care of folks who might need those services like you described. What a wonderful sense of community that you're already, that you're building in an already strong community in your area.
Yeah, it's been a great part. It's a small aspect of our clinic, but it's very exciting. And the new challenge that these people had with COVID was, since international travel was banned for many months, they stayed back and they ran out of their medications. So we got a lot of calls for refills, because when our parents come from India, they get about 6 months worth of medications from there, and they run out of them if they stay back here. So now we have people staying back for more than 6 months. They're here for a year now, just because it's so difficult to travel and it's high risk to travel. So this time we could see a lot of patients just to refill their medications, continue doing their lab, monitor medical conditions.
When you touch on COVID, because it has affected us all, are there any other ways that COVID has affected or changed your practice?
Well, changed in the sense more people are using telemedicine now. We always offered telemedicine. We use an app to make telemedicine and virtual visits easier. So our patients were well educated on the app, and I think COVID and then the lockdowns did not affect us too much. In that sense, we could still continue our care for our patients. Patients could still have their virtual visits, and we screen patients to be seen once the immediate lockdowns were lifted, that we could see them for non-urgent visits too, based on their clinical symptoms.
In terms of types of patient visits, do you, in addition to telemedicine and in-person clinic visits, do you also offer home visits?
Yes, we do offer home visits. And of course, it has to be medically justified to do a home visit. I don't see, I have to be frank, it's not a very common thing, for a common scenario to do a home visit for me. I have done probably 3 or 4 home visits, and they have all been in instances where maybe a patient could not travel due to certain medical conditions, that they could not get out of the house. So those, and yes, those were the scenarios where I would justify that, okay, yes, let's do a home visit, and we could offer that.
Are your home visits included in part of the membership as well to a certain extent, or do you charge extra for those home visits?
It's not included in the membership. We felt that it takes a lot of time. It depends. Houston, the drive itself is about 20 to 30 minutes, even within the same community. So it takes a lot of time. So it is charged extra. My home visits have been 2 hours minimum, including driving time. So it's a lot. And sometimes it's after clinic hours too. And to tell you frankly, there's the 2 types of home visits I did was, one of the patients needed a hospice evaluation, like a second opinion. They were having a hard time with hospice and accepting the fact. So I did that as a home visit twice. And then another time when, this unique scenario where there is we have an older patient who could not get physical therapy. She had a hip surgery, and she got COVID in the skilled nursing, so they would not do physical therapy for her. So it's been 3 months since her surgery, and she cannot walk now. So I had to go evaluate her and then get physical therapy to come and see her. So that was the other home visits I did. And she needed joint injections. She needed knee injections. So those were 2 unique scenarios where I thought that was worth doing the home visits.
Just hearing you say that, I think about how you've gone in just a few years from 45 patients with impersonal care to what you just described. I mean, how meaningful was that, and how valuable was that to the person who couldn't have physical therapy because of COVID? That's heartbreaking, but also wonderful to hear that you were able to fulfill that need.
Yeah, and that's what we can do, because that is the whole principle behind the DPC.
As you have grown over time, do you have any thoughts about churn in your practice and how you've used strategies specifically for retention and lowering churn as much as possible?
Yes, there is churn, and I think we all experience it. But I think Sunil here is more prepared to talk about it.
Yeah, I am the business guy, so I can talk about the churn. Yeah, definitely. There is, I mean, in any subscription business, there is always going to be a churn, and everybody should accept that that there's going to be a churn. And initially, when we, of course, I mean, we were full time from 2019. That's when she moved from her hospitalist job. She was doing 50% at that time in 2018. 2019 was the proper 100% all in. That's when we started, and our focus then was to get as many patients as possible, and fill up our patient panel, because now both of us are completely dependent of this, and we wanted to grow as fast as we could. And there is a problem with that, because not everybody understands the DPC model. It might be wonderful, but people don't understand this. Even today, people do not understand, paying subscription fees for primary care, because it's not. People understand, if there's a pain, you pay to fix that. That's very easy to understand. But you pay a subscription fee to prevent something in the future. That's not something that everybody can understand. It's not very easy to understand. And so that value of a subscription, I've described this as an amortization of, you might use it in bursts, and then you amortize it over time, but none of those really register. And that's been a problem where, if you do not kind of interview the families, or of course business is different. Small business, they understand it well, but this is more problem with families that's joining, and also people who are joining just because they have acute visits. So these are the things that we have learned, that when somebody wants to join, and if there's some acute visit that they want covered, or they don't really understand, but they just want to have doctor's services, that's the red flag that that they're really not going to stay much longer. And the churn is usually where people just join because they wanted to get services, and every practice will get this. So we transition from, let's focus on just bringing on as many patients as possible, to let's make sure that we are both fit for each other. So we never looked at fit in 2019, early 2019s, but we started thinking in terms of fit, that, they should feel that we are a good fit for them as a clinic, and we should have a good fit as a patient, so that they understand the value what we are bringing. And so when we started to do that, the churn really came down from what it was initially. And even during COVID, we were very cognizant of the fact that there was a lot of financial hardships. So we have helped with pausing their membership for a couple of months, helping them with that. And those things are the ones we had to do those in order to kind of help them when it was not very easy for them. If it's a question between putting food on the table and healthcare, the choice is obvious. So these are some of the things that we learned. I mean, these are all the things that we learned along the way. But I think the central idea that really works is, as long as we care for our members, there is a lot of trust and loyalty, and that cuts the churn.
On that note, you guys recently were involved with the RIP medical debt program.
Yeah, RIP is a national thing. It's a fantastic cause that is very close to DPC practices. And so we are at, I think, about close to 40% of our goal, which is $2 million, which is raising $20,000 to pay for or end $2 million of debt. I think we are close to about $8,000 now. We will get to $10,000 soon. We decided that's one of the great causes that we should contribute to. Of course, our community helped us, and they are still helping us raise the money.
With regards to the money that you guys are raising, how does that money get distributed, or does it go to a bigger pool? And how do people apply for medical debt relief?
So the way RIP works, it's a nonprofit organization. So the money goes to them, and they have a very good model where the donations to RIP is tax deductible. So that's a great thing. You can deduct in your taxes. What they do is they buy these debts from these agencies that hold these debts, collection agencies. And I think they bundle that in a financial, they bundle all these debts. And raising $2 million is probably is going to help maybe 20, 30 families. So they're going to buy that debt and then give those as gifts to these families when we reach that goal. So that way, the contributions are tax deductible. And when they give it as a gift, I think there's some clause, they call it the goodness of the heart gift. There's no gift tax from the government. It's ridiculous that they're going to tax this as well. But they have a way where they can gift this back to the families, to clear their debts. So that way it works both ways. For the donors, it's tax deductible. And for the people, that have the debt, there's no tax for them to clear the debt.
Speaking of medical costs and trying to avoid medical debt, do your patients use any health shares? And does that help you with retention of your patients?
Yeah, we have patients that use health share. We have a mix of patients. We have patients with HDHP insurances, and then we have a lot of people without insurance, any kind of insurance. And then we have some that are using health share. And in terms of retention, I don't think it really has any effect in terms of retention, whether they have health share or not. I mean, I have not seen any major change. It's one way of them covering for their major medical, but and it's a great way too. But again, I think still health sharing is in early days. Not many people know about health sharing. And those who know really don't understand it because there's a lot of fear about claims not being paid. I think health sharing guys, they hate when I say claims. They use some other language for that. But there's a fear among people that these things will not be paid because it's not really a legal contract. And that was one of the questions I asked when we interviewed health sharing companies. Was there is this fear, and how do you guys answer that? And so health sharing is really not very well known, and I think there's a lot of catching up to do for health sharing companies, and DPCs can help in kind of spreading the word, and which is what we do. And as a clinic, we are neutral in the sense that we give these options to all of the options that's available in the market to the patients, or tell them about it. And it's finally, ultimately, it's their choice whether they want to have insurance or they want to have health sharing or they don't want to have any kind of coverage, and bear the risk themselves. It's ultimately their choice, but we will tell them about what we do and what part of their medical care we cover and what is left, because that's very important. Because I talk to the small businesses and the families when when they're looking to join, when we do meet and greets, I talk to them. And so I've talked to hundreds of people over the last couple of years. And whenever they say, okay, what kind of insurance you guys are providing, and I correct them, no, we are not insurance. So even the back of their mind, they always think that we are some kind of insurance. And then I have to tell them, it's 80-20. 80% of the things that the health issues can be treated in a primary care clinic, and it's a subscription. And it's not an insurance. Insurance is that 20% big part, where you go to a specialist or you go to a hospital or ER. That's when you need the coverage and all that. And kind of, educating them about what is insurance, what needs to be insured, and what is just a wear and tear kind of thing compared to a car. So that those things are not really well known. And even today, I know that DPC is much more known now, but it's not well known yet. Same with health sharing. It's known, but it's not well known. It might, especially business owners, probably because they do a lot of research, they might have known about all of these, but it's still not mainstream. So DPC is getting to mainstream. Health sharing is getting to mainstream, but it's not really mainstream, in that sense.
When you talk about employer groups, you guys have used a broker in the past. Can you share about your experience using a broker to entice employers to join DPC or have their employees join DPC?
Yeah, the experience has not been good at all. I think the role of incentives is the problem, because they're not incentivized to sell plans that do not provide them with bigger commissions. And with the plans that they really sell, DPC doesn't go with it, because it's like paying twice, and nobody wants to do that. So it's very hard to get brokers, and there are some very good brokers that understand and that want to do the right thing and that see what's coming. And I think eventually everybody is going to have to change to this model. But right now, the majority of them, do not understand DPC or don't want to do it because of incentives that are not really in their favor. But those that want to do it, they are very good about offering us as an option that they can add on to the coverage that they can provide, especially after COVID, where a lot of their options are now no longer feasible for these companies. And when that was a situation, they thought of offering us an lower plan tied to the other plan as an alternative that these companies can have rather than go without any insurance. So DPC has been good in that sense to kind of increase our presence there. But again, it's all about incentives, and I think there's a long way to go for brokers to understand. I know Health Rosetta and all these guys are doing great things, but yeah, all of those still need to become mainstream yet. And so, which is a very good thing, because that shows that there's a long way to go, and there's a lot of things that we can do and to grow. There's a lot of space for us to grow, and that's a great thing. So we're not in a saturated market. In business lingo, they say the blue ocean and red ocean, where red ocean is where there's a lot of competition, and one guy is killing another guy and it's all red with blood. We are in the blue ocean where there's nobody else. And that's where you grow. And I think DPC is positioned in that fantastic space. And I think things will turn in our favor. But also, another thing I wanted to kind of add on to your question is DPC as a whole should also think of what will break the camel's back. Legislation, overnight can change things. And the reason why I bring this up is I was talking to a small business family that had come yesterday to a clinic. And that's one of the things that they brought up was, hey, what if they bring back individual mandate? How does that affect us? I've not seen any of these discussions in any of the DPC forums. Things like what will happen if these political things change, legislations change. Are we prepared for that? There might be discussions going on, but yeah, I'm not aware of those. So I think these are the things that whenever I see these forums, it's all about good news. But I think we should also kind of start thinking about what might break us and be prepared with solutions when these things happen.
What are some of the things that you guys have brainstormed about to weather the storm if legislative changes happen, specifically in Texas?
No, we have not. I mean, if there's like, for example, individual mandate, we have to change our business model to kind of accommodate that change, and what we will do, all of those things. These are the things that we are brainstorming, and we don't have a solution yet that might be feasible. And so this is kind of, I think it's an ongoing thing. It might not be overnight. These things don't happen overnight, but who knows what will happen in the next couple of years. But then I think as a group, there needs to be a think about what will break us and how do we kind of insulate ourselves when these kind of situations arise, and how do we pivot and how do we manage all of those things. So that should be front and center moving forward, because these political climates will change, and so DPC should not be tied to any of these. It should be there in any environment and thrive in any environment. So what should DPC as a group need to make sure that we thrive in any political environment?
And it's so important because it goes to the heart of DPC, right? It's equalizing healthcare to make it accessible to all, rather than certain people who can afford a high concierge price. The whole point of DPC is to provide excellent, personable healthcare to everybody.
Yes.
Now, with regards to the current situation and weathering the storm, you guys are in Texas where there are restrictions on self-dispensing. So can you touch on, are there any other challenges that you feel you have because you're in Texas? And how do you get past those challenges, whether it be self-dispensing or other challenges because of your geographic location?
Yes, unfortunately, we don't have self-dispensing, but we work with several prescription programs, discount programs. We educate patients on asking for cash pricing, because a lot of times they are not told that a medication has got better options for pricing. For example, just today, I prescribed Humalog or Novolog 7030, and he got dispensed a brand name despite me sending a brand name not required prescription, and he didn't know about it. And then when I followed up on him, he said that it costed me $123 on GoodRx, and the pharmacy asked that it had to be specified that it needed to be generic for them to dispense generic. And this was a big name pharmacy. So this is what we deal with on a daily basis. So there's a lot of savings to be made, even when we educate patients on the generic versus brand name, on which pharmacies to choose and where to go to get your medications based on the pricing we see. So, I feel like even though we cannot dispense our own medications, we have a lot to do with education, making sure the patients have the right discount cards and educating them on how medications are priced in different pharmacies.
Do you guys have any tech or tools that you use and love in your practice?
Technology-wise, we use the Spruce Health app, Hint, and Elation combination. And I think yes, of course, I think no system is perfect, but we have had more success. I think Spruce app is a game changer. I really love it in communication, and it's gotten better and better. They're very responsive, and of course, Hint has been very responsive and very easy to work with any questions answered, any new configurations that we want. And Sunil has been in constant contact with them. I'm still in search of a good autoclave, which I can buy or afford without, buying a brand new one. But I think, I feel like when people are thinking about starting clinics like this, like DPC clinics, buy as you go and build on what you need, rather than have a whole list and then just go and do a big shopping day. That way you understand what you need and you're growing steadily and you're not investing a whole lot of money on things. We also realize that a lot of these expire. So you have to be cautious on what you're spending. So my shopping has always been that way. My shopping has, I never had a big shopping list. I have always added as I have learned and educated myself on that.
Do you have any specific shopping strategies that you use for particular items? Like, do you look up strategically an item in different GPOs, or how do you go about finding the best value for your patients?
Well, I've looked at several places. We look for not really a lot of instruments for patients, but yes, medical supply stores. And as we have I think I've looked up, of course, I used to order things from McKesson because I didn't know the local suppliers. But as we got more popular, we networked with more local suppliers for things like flu tests and strep tests, which I could get for a much more cost effective way, especially flu vaccines. I can just text my vendor and he will get it delivered to my office at my time. So that's been a great convenience. When I do that with McKesson, it's like I'm on a waiting list. Nobody's there to talk to me. But this is the changes that I have seen, and I feel like I've known the community better, and then I know the people where I'm going to order things from.
Do you guys have any additional advice for those who are entering the DPC or direct care space?
Well, it's a very exciting space, but then, we really recommend educating yourself very well, knowing the risks and yes, Sunil wants to add something here.
The most important thing is, and this is based on what I see on Facebook groups and other places where people I see, when people are interested to open, there's a very happy picture that's painted that everything is going to be easy. You just need to start, and next day or maybe next month, you'll have a full panel. That's not how it works. There might be a handful of them that might have that kind of maybe in a place where they get more patients and fill up faster. But I think for most of us, it is hard work. It is a slow process. It is a process that needs a lot of patience. And if people jump into this thinking that they're going to have a full panel in the next month, they will be very disappointed. So I think that realistic picture needs to be painted for people who are entering now or who want to join or start their own. And so, yeah, I think that's a big advice. But don't let that be a hindrance to start this, because this is, like I said, this is a blue ocean. So the possibilities of growing is unlimited. The sky is the limit for this. So the DPC will grow, and people. This is going to be more well known. It is going to be mainstream, and people will naturally come. But then it will take time for that to happen, and so people need to be ready for that. They need to be patient about, have a lot of patience to, get their next member and work on getting one by one, and not think of filling it up quickly. And which was a big mistake that we did initially, was to go for numbers. It has its own issues. So yeah, that's a big advice from non-medical side.
When you guys speak of the importance of educating oneself as they explore DPC or grow in DPC, have you found any resources that you find extremely helpful? You've mentioned the Facebook groups, but are there any others that you could recommend?
Yeah, I mean, of course, the SBA has a lot of business tools. So if doctors want to learn the business side, the Small Business Administration website has a lot of tools about starting business, like marketing, sales, and a lot of things about that. So business side, yes, there are a lot of tools, free tools that's available. But also, that's not something, up to a point a doctor should be involved into that in that. But that shouldn't become a main thing, because for doctors, the main job is to care for their patients and not worry about the business side. At some point of time, it should be kind of offloaded to people who can run the business. At least in our case, we could share those responsibilities, where she runs the medical side and I run the business side. But for those who want to learn, and it's definitely, I think Bhavana touched upon that the doctors need to know the business and know how the business is set up and how it is run. But at some point they have to kind of give it up and make sure that their main focus is on caring to patients.
How do others reach out to you in the future?
Yeah, they can email us or look us up on Facebook. Email is info@springsmd.com. They can reach out to us on that email. We are on all of the social media at SpringsMD is Twitter, SpringsMD on Facebook, and we even have a YouTube channel. You can just search for Meridian Springs Primary Care, and so we are available. You can message me on Instagram at SpringsMD. We have an Instagram account there, and so yeah, there are several ways you can reach us.
Thank you so much, Dr. Rao and Sunil, for joining us today.
Thanks, Marielle. We enjoyed talking to you.
Yeah, Marielle, thank you so much for having us. It was a real pleasure talking to you and, reliving all the memories of starting the clinic. It never gets old.
Next week, look forward to hearing from Dr. Phil Eskew of DPC Frontier and Proactive MD. He gives an answer to the question, what, if anything, could break DPC, and much more. If you like what you heard today, please leave a review and subscribe wherever you listen to your podcasts. Tell your friends, too. Also, for the latest in DPC news, check out dpcnews.com. For more information on this episode and much more, please visit mydpcstory.com. Until next week, this is Marielle Concepcion.